Happy 2021, everyone, and welcome to the RAS-ACS Behind the Knife Journalcast on Landmark Papers in Surgery. I'm Ryan Huttinger, a general surgery resident from Cape Fear Valley Medical Center, and I'll be reviewing the SMART trial, which compared the use of balanced crystalloids with normal saline in critically ill adult patients. This article was originally posted in the New England Journal of Medicine in February of 2018. The rationale behind this randomized controlled trial was to compare the outcomes of traditional crystalloid use, normal saline, and electrolytically balanced fluid, such as lactated ringers and plasmolyte, in regard to 30-day mortality, the need for renal replacement therapy, and persistent renal dysfunction at 30 days. Normal saline may have deleterious effects on the body, specifically on renal function. More specifically, in several recent studies, it has been postulated that normal saline may cause hyperchloremia, which in turn may reduce renal blood flow, conferring a higher risk of renal replacement therapy, as well as increased mortality, specifically in critically ill patients. Additionally, normal saline, when given in large volumes, may cause metabolic acidosis, which is problematic in critically ill adults. The population under study included 15,802 critically ill adult patients admitted to intensive care units at a single institution. Patients had a wide array of pathology causing critical illness, with the most common diagnosis being sepsis. Patients were across 5 ICUs, including medical ICU, surgical ICU, cardiac surgery ICU, trauma ICU, and neuro ICU. The rate of acute kidney injury in the total population was approximately 8.4%. Additionally, 1/3 of patients were mechanically ventilated at time of enrollment, with 1/4 requiring vasopressors. The two cohorts were similar at baseline. In this trial, patients were randomized to receive either normal saline or balanced solutions of plasmolyte or lactated ringers, depending upon the ICU they were admitted to. The fluids were changed across the entire ICU on the calendar month so that all patients in each individual ICU would receive the same fluids for that month. A total of 7,860 patients received normal saline, and 7,942 received lactated ringers or plasmolyte. The volumes and rates of fluid therapy were determined by the medical judgment of the treating providers. Additionally, physicians were able to switch the prescribed fluid at their discretion if deemed necessary. For example, a patient with hyperkalemia assigned to the balanced crystalloid group may be switched to the normal saline group if deemed necessary by provider. Of note, patients were permitted crossover from control to experimental group and vice versa. Additionally, patients remaining in the ICU past the change of the calendar month were switched to alternate therapy. The patients were observed for the primary outcome or major adverse kidney events within 30 days. This study was designed with a primary composite outcome which looked at multiple perspectives of renal function. The components that comprise the primary outcome include mortality within 30 days, new need for renal replacement therapy, and persistent renal dysfunction, which the study defined as greater than 200% rise in creatinine above baseline. The results from this study, as shown in the table, revealed that of the 7,860 patients allotted to the normal saline group, 15.4% of patients had a major adverse kidney event within 30 days of hospitalization. Of those receiving balanced fluids, 14.3% experienced a major adverse kidney event. As you can see in the table, the p-value for the composite outcome was statistically significant at 0.04. However, when taken individually, these values were not statistically significant. There were additional secondary outcomes, including in-hospital mortality, ICU, ventilator, and vasopressor-free days, which were similar between groups. As the results were compiled, several subgroup analyses were performed, as the patient population included patients admitted to different ICUs with differing underlying pathology. When analyzed by type of ICU, balanced crystalloids were favorable in the medical and neurologic ICU cohorts. However, there was no significant difference for patients in the cardiac, trauma, or surgical ICUs. Patients who had an underlying diagnosis of sepsis had a significant improvement in the rates of primary outcome. 33.8% of patients reached the primary outcome in the balanced crystalloid group, compared to 38.9% in the normal saline group, with a p-value of 0.01. Interestingly, patients without traumatic brain injury showed that balanced crystalloids had improved outcomes. However, no significant difference was seen in patients with traumatic brain injury between normal saline and balanced crystalloid. Lastly, although there were no significant differences in the primary outcome for patients with normal kidney function, AKI, or CKD, patients who had previously required renal replacement therapy had improved outcomes in the balanced crystalloid group. The authors' conclusions from this study were that in critically ill adults, this trial supports balanced crystalloid administration over saline to decrease composite outcome of death, need for new renal replacement therapy, or persistent renal dysfunction. The strengths of this study include that it was a large study powered to detect even minute differences in outcomes. Additionally, the study population was comprised of a diverse cohort of medical and surgical patients. This study unfortunately did have some limitations, including that a composite outcome may exaggerate the results as a single endpoint. Additionally, the patients within the trial received on average 1 liter of IV fluids during the study, which is a fairly low volume for a critically ill population. Given that this was a single institution study, implicit selection bias may have been present. Lastly, providers were not blinded to study groups, which could also introduce bias. Overall, this was a large randomized controlled trial which did purport that balanced crystalloid fluids confers benefit versus saline in relation to major adverse kidney events in critically ill adult patients. However, these findings should be taken with a grain of salt in relation to the patient population we typically treat as surgical residents, as there was no benefit seen in the patients in the trauma or surgical ICUs. I'm Ryan Huttinger. This has been another presentation of Behind the Knife Landmark Papers Journalcast. Thank you for watching. If you have any questions or comments, please feel free to reach out to me through my email, rhuttinger@capefearvalley.com.